or non-vigorous 35 to 42 vigors. Second, regarding the involvement of the removal of the routine suctioning for in the initial steps, which involve the dry position, uh, the tactile stimulation. Clearing of the airway is only recommended if visible secretion or obstruction of the airway is there. Third, regarding the ventilation corrective steps, which are now the time duration has been become more flexible from 15 to 30 seconds, and the fixed pattern which was used before regarding the MR SOPA is now become flexible depending upon the resuscitator. The target oxygen saturation table has now been updated, in which the first minute targets are removed. Regarding the use of laryngeal mask airway, ventilation can be initiated using the LMA as a primary airway, which was previously as a rescue airway, which was used. Regarding the FiO2 to be used as initial FiO2 in more than equal to 35 weekers, 21% FiO2 is recommended, while for 32 to 34 weekers, 21 to 30% of FiO2 is recommended, and for less than 32 weekers, more than equal to 30% FiO2 can be used. For the initial PIP to be used, which has now become initial PIP is kept at 25 plus minus 5 centimeter. For more than equal to 32 weekers, it is to be kept at 25 to 30 centimeter of water. And for less than 32 weekers, it should be kept at 20 to 25 centimeter of water. So after chest compression, it is reliable. If reliable pulse oximeter signal is achieved, this FiO2 can be adjusted to the target SpO2 that we that based on the minutes of life. Regarding the endotracheal tube size, this has also been modified regarding the gestation age and weight. The tube size of 2.5 and if optional available, 2 mm size ET tube is to be used for 22 to 25 weekers or less than 800 grams. For 26 to 28 weekers, 2.5 mm ET size is to be used for also for 800 to 1200 grams. For 1201 to 2200 grams and 29 week to 34 weekers, 3 mm size ET to be used. And for more than 2200 grams and more than 34 weekers, 3.5 mm size ET tube is to be used. Regarding depth of insertion, which was previously from tip to lip, now been changed to tip to mid part of the maxillary gum. And that's it. Okay, ma'am, you can go ahead.
You can go ahead with this newer changes in the 3 algorithms, which is being taken into account, which was not there a part of NRP before.
Okay, ma'am. So regarding the resuscitation and stabilization in the newborn with suspected CHD, again here the pre-delivery questions are somewhat different from the routine NRP, in which the 6 cardiac specific pre-delivery questions need to be asked, which includes first, which in which are we anticipating the infant will be unstable or have the cardiorespiratory failure immediately after birth. Second, are there any additional features to consider for this CSD that increase the risk for cardiorespiratory failure or other complications immediately after birth? Third question will be, does this CSD require any modification to the heart rate targets, which we are using in NRP? Again, fourth question will be, does this CSD require any modification to the target oxygen saturation, which we are targeting? Also, titration of the FiO2, which is to be required. Fifth question will be, is this CSD expected to cause any problems with systemic blood flow and perfusion? And the last will be, what additional equipments, medication, and personnel are to be required? So it is said that most of the newborn infants with CSD will be vigorous after birth, And if resuscitation is required, it is not likely to be because of the underlying cardiac defect, but more likely uh, except for those with a few specific critical cardiac congenital heart diseases. Infants with CHDs who are not vigorous immediately after birth should be treated using the same steps as given in the NRP algorithm. Based on anatomy and blood flow patterns, newborn infants with specific CCHDs will require modification to the steps of the neonatal resuscitation and the target oxygen saturation. Again, supplemental oxygen should be given to newborn infants with CHDs to maintain their pre-rectal oxygen saturation within the target range specified before birth, based on their expected anatomy and physiology. Fetal echo is helpful but cannot accurately predict if the amount of the atrial mixing is sufficient to support the newborn infant with certain CCHDs. Again, if a newborn infant with CCHD is not responding to the recommended steps of stabilization, cardiology consultant can be consulted for the additional expertise. So, for example, this is for the TOF case, tautology of related cause of the cardiorespiratory failure at birth, in which the preductus is pure to uh, target will be in the case of, for example, in the case of TOF with mild pulmonary valve stenosis, the saturations will be near normal. So prostaglandin is usually not recommended or not required. While in the case of TOF with severe pulmonary valve stenosis, the target saturation will be 75 to 85% with prostaglandin required in this case. TOF with pulmonary valve atresia, again target will be 75 to 85% with PGE required in the postnatal management. While TOF with pulmonary valve atresia and MAPCAS, another example in the hyperplastic left heart syndrome with uh, stabilization steps to consider are intubation, sedation, and paralyze the newborn, prostaglandin infusion, emergent cardiology interventions. Other interventions include again intubation, sedation, prone positioning, other
So,
accurate vascular access,
so in short,
rate
what
control
they
with
did was,
adenosine,
uh,
cardio.
just a minute, Aman. In short, what they did
Yeah.
was they have specified certain recommendations for stabilizing the babies with a congenital heart disease, which are at risk. And they have given some
Mm.
additional steps in the terms of how to handle such instability in the delivery room, taking into consideration that most of the neonates which are presenting, even with critical congenital heart disease, might not present at the time of birth. But in case if you have an anticipated delivery and there are certain critical congenital heart disease which you might be dealing with, in the labor room, these are certain additional steps which were given by the NRP, which could be taken into account depending on the case based scenarios.
Yes. For example, if the newborn is with CHDs, regarding resuscitation in the neonatal ICUs, uh, again the initial priority will be effective ventilation of the lungs when resuscitating most of the infants in an ICU. Also, as these newborns will be presenting usually in the postnatal period, underlying health conditions often contribute to clinical decompensation in an ICU and must be considered during both resuscitation and post-resuscitation care. Again, infant requiring resuscitation in the ICUs have usually completed their initial physiological transition and may already be receiving some sort of respiratory support and have vascular access. Again, during the chest compression, it is reasonable to coordinate ventilation compression using the NRP 3:1. But if arrest is primarily cardiac, here the pulse ratio of 15:2 is to be used and may be appropriate to use.
So basically, the idea of introducing this new chapter on resuscitation in the neonatal intensive care unit was whole basically due to the fact that the resuscitation inside a NICU is already a little different as compared to what we are dealing it in the labor room. And we already have a vascular access. Most of these babies have already undergone that physiological transition. Most of the steps remains the same. Like for example, in a neonatal resuscitation, the ventilation forms the utmost priority. So the steps remain the same, but there's certain consideration of the underlying health that has to be taken into account if a neonate has to be resuscitated in the neonatal intensive care unit. So there are certain other things as well which is to be contributed. Go ahead, Aman. Aman, you can go ahead.
Again, so there is no fixed gestational or postnatal age cutoff for switching from the NRP to PAS, as we have seen. So the etiology of the event should guide the choice of the algorithm. Tamponade, it should be considered if the infant with deteriorates. Again, tachyarrhythmias with no pulse, manage using the PAS cardiac arrest algorithm. Emergency response, start high quality chest compression immediately. If ventricular tachycardia or ventricular fibrillation is, so this is based mostly on the PAS guidelines, is to be followed in NICUs. If you are considering the metabolic cause for it is severe so suspected severe hyperkalemia. NRP key behavioral skills are applicable to resuscitation performed in NICU. An ICU specific code response plan that includes early recognition, teamwork training, debriefing, and focus on quality improvement is important to optimize the team response.
Now, this is the last part, that is resuscitation outside the delivery room.
So core NRP principles remain unchanged, even outside the delivery room. Again, ventilation is the first priority for all the newborn resuscitations. But essential equipments that can be used are bulb syringe, bag and mask. And this must be readily available wherever newborn receive care. After ensuring the ventilation, we have to review the infant's history to guide the further steps. Again, 3:1 compression to ventilation ratio is to be used. Modify if primary cardiac cause is suspected, which can be modified to 15:2 as in the PAS guidelines. No fixed age to switch to PAS. Decision on cause of the arrest, respiratory versus cardiac.
I think this ends our presentation. We'll be happy to take if there are any questions.
There was one question regarding use of ECG.
Aman, would you take up this question? Will you be able to take up this question? Role of ECG?
Currently, I think pulse oximeter is only recommended in the NRP guidelines, ECG.
Basically, the use of the cardiac monitor still remains unchanged. It is as per the previous guidelines, which was given previously. So it clearly states that whenever you are starting with the ventilation, the positive pressure ventilation, the terminology which has now been upgraded to ventilation. So whenever you are attaching a pulse oximeter, it is recommended to consider the cardiac monitor at the same time. So the role of ECG actually remains exactly the same as it was there in the previous guidelines. So the whole idea of this changes in the NRP, even which is stated in the formal presentation by the NRP steering group also, was to make the guidelines more practical, and that could be easily seen in the changes which is being depicted as combined as well. So most of the changes which are made is to make the practice more practical. Sir, any additional point from your end, sir?
No, I think Aman had covered all the salient features. So this last slide also summarizes whatever changes have been done and why they were being done. So the rest of the guidelines are same. The major focus is on one delayed code clamping, which has now been more um, protocolized, and confusions have been cleared regarding umbilical cord management. The another is ET tube insertion length, and then initial FIO2, which has been liberalized in babies who are less than 32 weeks. So I think these salient features need to be taken into consideration. And they've also clarified whatever methods of resuscitation to be taken place outside delivery room, which almost remains same when the baby is in NICU, except a few cardiac events like tachyarrhythmias with pulseless tachyarrhythmias. So NRP is basically evidence-based protocol which have been revised time to time to protocolize the resuscitation. And as you all know that it is the ventilation remains the cornerstone of newborn resuscitation, and that has to be established on priority. So that's all.
Thank you, Aman. I hope the presentation would have benefited many DM and the DRNB students who have attended it. So thank you everyone for joining. And thank you, sir, for...
There's one question: why the terminology has changed from suction to clear airway? Any difference between the two? Yeah.
So as we have already stated, I'll just depict the slide again, that why there was a change which is being made. The overall reasoning was although it was it's actually based on this evidence update which was conducted in 2025. Even in the previous NRP, they have emphasized the point that suction only if it is required. It has been re-emphasized up to based upon this QI study, which is done in around 1,000 infants, where they have done, avoided the suctioning, and they have found that there are only 4% of the neonates which actually requires the suction. While in the phase 1, it is around 12% of the neonates which have undergone the oropharyngeal suctioning. So, although we don't have, as all the part of the NRP guidelines which is being taken into account, we don't have much evidence in the term which could say that it is based on the strong recommendation, although it's based upon again a weak the weak recommendation and the low quality of evidence itself. But it has been found that unnecessary suction could be avoided, and that's the reason why this word suction has been removed and it has been replaced by clearing the secretion, just to re-emphasize the point that it is the clearing of the secretion to be done only and only when it is required, not to be done as a routine practice. The terminology has been changed only to re-emphasize the point to avoid unnecessary suctioning. So I hope there
Yeah,
are...
so clearing the airway. Yeah, so clearing suctioning is one method of clearing the airway. So you can wipe the mouth and clean the nose by a sterile gauze also. And majority of the time it is sufficient. Suctioning is not needed. The second is suctioning itself is a harmful activity sometimes because it stimulates posterior pharyngeal wall and can lead to bradycardia. So clearing airway includes suctioning and clearing the airway by a gauze wrapped on your finger and just wiping the mouth by clean gauze. And majority of the time, cleaning the airway or the mouth by gauze is sufficient, and you do not require suctioning. So just to emphasize that suctioning is just one part. Your aim is not to suck. Your aim is to clear the airway. Suctioning may be needed if it is required. So that's the reason why the terminology has been changed.
Since there are no more questions, sir, can we just end the
Yeah.
session? Thank you everyone for joining. We're just ending the session and we will be sharing the recording and the presentation in the groups. Thank you, sir.
Thank you,
Thank
ma'am.
you.
Thank you, sir.
Thank you.